Assalamualaikum. I'm Dr. Sanamjad, and I'm mentor of PrepXperts Online Academy, and we are here to discuss about the very important module of for MRCOG Part 1. Okay, so previously we have discussed about in our introductory session everything about MRCOG Part 1 exam, that how you should book the exam, how you should start preparing for exam, and what will be you be having in our course schedule. So if you have any query regarding that introductory session, you can ask me now as well. Then we should start with our preparation. So this is our course. This is our premium course for the MRCG Part 1. If you are willing to give this January exam, which will be on 21st January 2025, then you all must have submitted your eligibility form, your expression of interest form. Okay, so these two things were very important. So if you are done with that, then now is the time to start preparing for the exam. Okay, so in our course, basically, we will be this course is for the whole 4 months, approximately 4.5 months duration. And in this course, you will be getting. You will be having the module wise your whole syllabus will be covered, and we will start with one module, and then at the end of the module you will be having some weekly test. Okay, so that you can practice as many SPs as possible. So we will be giving you approximately 3 classes every week. You can say alternate day you will be having classes, and if you miss any live class, you will be provided the recorded sessions, so you can listen to that sessions later on. And you will be having, at the end of all the curriculum completed, you will be having a recalls classes, so that your all the recalls of approximately 5 years duration, that will be covered as well. Okay, so starting from today, I have selected the very longest module in firstly, and that's a very important module as well, which is anatomy. And you must be having questions, approximately 20 to 25 questions from this module. Okay, so it is a very, very important module. You cannot miss or you cannot skip anything in this module. And these are very actually basic questions. They usually come from anatomy, so you can actually attempt all these questions very easily and very correctly. So starting with the anatomy module, and this is actually this anatomy module, it is basically divided into these topics. I will be giving you lectures one by one from these modules, because you don't have to read anything, whole the anatomy of whole the human body. You don't have to read the head and neck and the limbs. Okay, so everything of anatomy will be related to your obstetrics and gynecology, nothing else. Like first we will be starting with the abdominal wall. Okay, so abdominal wall is very important. Then we will be going to the peritoneal cavity, but not the whole details of peritoneal cavity and every organ you have to read. No, nothing like that. Okay, the most important thing which is related to your gynae is the pelvis. So you'll be reading the pelvic bones, the pelvic joints, every organ inside the pelvis, and all the genital organs. These are the very important. And then move on to the vascular and neuroanatomy. Now you don't need all the vascular system you have to read. No, only related to your gynae, means only related to your pelvic organs as well. So we'll be seeing this abdominal aorta, like what are the branches of abdominal aorta, where it bifurcates, and which artery supply, which organ. So that's important for your this exam. And then in neuroanatomy, we'll be reading a few plexuses, and that will be also related to the abdominal pelvis. Okay? And in endocrine anatomy, we will be discussing, because you have to read the hypothalamic hormones, we'll be discussing the pituitary hormones. So the hypothalamus and pituitary anatomy is also important, and also adrenal, thyroid, like all the hormones which are related to our gynae. And the most important is fetal skull. Okay, So this is the brief overview of anatomy module, what you have to cover in this module, okay? So we cannot cover the whole anatomy in one session. So starting with the abdominal wall, I have picked just a basic and easiest one with the anatomy. So this is the abdominal wall. We will starting with the anterior abdominal wall, okay? So this is a very, very important trunk surface anatomy. You all have read that previously in all your exams, how the trunk surface anatomy, how the abdomen is divided into 9 quadrants, okay? So we divide the abdomen into two, with the 2 horizontal and 2 vertical lines into these 9 quadrants. See, this is the right hypochondrium, then the left hypochondrium, right lumbar, right iliac, left iliac fossa, okay? And in the middle, upward is the epigastric, then umbilical, and the hypogastric, okay? So this is the basic overview, but what's important in this trunk surface anatomy is, see, this is the horizontal plane. What is it is called? This is the transpyloric plane, okay? Actually, the name indicates also the transpyloric means it crosses the pylorus of stomach, okay? So this plane is very, very important for your exam purpose as well. Okay, then the second one plane is the transtubercular plane. I'll discuss it in later. First, this is transpyloric plane of Addison. Okay, where it lies? This plane, actually, it lies halfway between the suprasternal notch and pubis. See, this is the pubis. Here is the sternum, and suprasternal notch is here. Okay, so if you draw a line, and it is the midway between the suprasternal notch and pubis is the transpyloric plane, okay? And it lies at the level of L1 vertebra. Now, this is a very, very important exam question. It comes very frequently that they can ask you the different way as well, like where the transpyloric plane lies at which vertebral level, L1, or they can ask you at an L1 vertebra which plane lies, okay? That's a transpyloric plane. And also very important things that at this plane, which things crosses. So the name indicates this is the pylorus of stomach. That's why it is called transpyloric plane. So first thing is pylorus of stomach, then there is the pancreatic neck, and then there is the duodenojejunal flexure, and then there's the fundus of gallbladder, only fundus, okay? Then tip of ninth costal cartilage. See, this is the costal margin and it crosses the ninth costal cartilage, okay? Then the renal hilum. These 6 things, these are very important. You have to remember these. They can ask you like this at transpyloric plane. They can ask you which one, they give you multiple options and they ask you which one lies at the transpyloric plane. So you must have to remember that these 6 things lie at the transpyloric plane so that you can correctly choose the correct option, okay? Now, another very important thing is that there's the spinal cord terminates at this level, means transpyloric plane. At this level, the spinal cord terminates. So it means spinal cord terminate at L1 level. See, this is a very, very important plane. So you have to remember this by heart. Okay. Now move on to the next planes. You have to remember these as well. So then next is the subcostal plane. Now the name indicates subcostal, means it will be the below costal margin. See, if you see this diagram, this is the transpyloric plane and it crosses and it goes at the L1 vertebra. Now this is the subcostal plane and here it goes below the costal margin. Okay? So it will be the below costal margin and it goes to the L3 vertebra. So below costal margin means that's the 10th costal cartilage, okay? 11 and 12, they do not make up the costal margin. The 10th is the 10th costal cartilage is the costal margin and it lies at the level of L3. So now L1 transpyloric plane, L3 subcostal plane, okay? Now next is the intercrystal plane. Crystal means iliac crests. So this plane is between 2 iliac crests. It's not actually drawn here, but if you see this is the iliac crest, then the iliac, it will be between here. So it will be between the iliac crests, okay? And it lies at the level of L4 vertebra. And then there's the intertubercular plane. See this, we discussed previously. So intertubercular plane, it joins the tubercles on the iliac crest. So the tubercles on iliac crest, they joined and they form the intertubercular plane, and it lies at the level of L5. Okay, so these three planes you have to remember. L1 transpyloric plane, L3 subcostal plane, L5 intertubercular plane. Okay, and L4 as well, if you can remember each and everything. So these planes are very important. So trunk surface anatomy, they usually ask one question from this, one or two as well. So if you can, you can just read this. You just have a basic knowledge that starting from T2, T2 is at the suprasternal notch. This T2 means the second thoracic vertebra. Okay, we are not discussing about the nerve root. We are discussing about vertebral levels. Okay, so this T2 means this is the second thoracic vertebra. It lies at the level of suprasternal notch. Then T5 is the angle of lower sternal angle. Then T9. Actually, xiphoid is always very important. So you can remember this level, T9 xiphoid. And then the same, this is transpyloric plane, L1. L3 is the subcostal plane. L4 is the iliac crest plane. Now, this plane has importance, very, very important. This is a very important exam question. It's come very frequently, that at which level aorta bifurcates, abdominal aorta bifurcates at L4 level. Okay, so L4 has a very much significance with this aorta bifurcation. Okay, and then this is the S2 posterior superior iliac spines, and here the dural sheath terminate. See, we discussed previously where spinal cord terminates. Spinal cord terminates at L1 level. Okay, but that was the transpyloric plane, and now dural sheath terminates at S2 level. So you have to remember like this as well. Okay, so all these vertebral levels, they are very important. They usually ask about the transpyloric plane, one question, and they usually ask about the aorta bifurcation as well. So these two questions, they usually come in exam. So you have to read this and remember these as well. Okay, now move on to the layers of anterior abdominal wall. So what are the layers of anterior abdominal wall? This is the very basic thing, that first is the skin, then move on to the fascia, which is superficial and deep fascia, then there are muscles, and then the extraperitoneal fascia, and then the parietal peritoneum, and through the parietal peritoneum you enter into peritoneal cavity. Okay, so see the diagram, it's a skin, and then this is the fascia. I will tell you in the next slide what's these names, Camper and Scarpa's fascia. Okay, so this fascia, then the after the fascia there's the muscles. There are three muscular layers. First the external oblique, then this fascia, then the internal oblique, and then the transverse abdominis muscle. Okay, so these three muscles are in the anterior abdominal wall, and they are layer by layer. Like external oblique is superior, and then the deep is the internal oblique, and then deep to internal oblique is transverse abdominis, and then the transversalis fascia, and then this is extraperitoneal fat, and separate parietal peritoneum. Okay, so all these layers are of the anterior abdominal wall. Whenever you give incision for the surgery, you have to go all these 6 layers. Okay, then you will enter into the peritoneal cavity. Okay, so just a brief overview of the skin of an abdominal wall. I don't think anything important in this. The skin is loosely attached to the underlying structures except at the umbilicus, which is tethered to the scar tissue. So basically, umbilicus is a scar. It represents the site of attachment of umbilical cord in the fetus, and it is situated in the linea alba. Okay, so this is a little bit important. The natural lines of cleavage in the skin, they are constant and run downward and forward, almost horizontally around the trunk. Like this is the abdomen, so the cleavage lines, they come downward and forward like this, horizontally. Okay, so what's the significance of these cleavage lines? Because if you give an incision along a cleavage line, it will heal as a narrow scar, But if the incision crosses the cleavage lines, then it will heal as a wide or heaped up scars. Like if we give in the gynae, if we see you give the transverse suprapubic incision, Venous incision, so they heal with a very narrow, there's very good healing of these horizontal scars, and they are healed as a narrow scar. But if you give the midline laparotomy incision or anything, a paramedian, so anything crosses these lines, then they will heal up as a wide or heaped up scars. Okay, so that's just the importance of the skin. And this is also a very important nerve supply of anterior abdominal wall. Okay, so anterior abdominal wall, it is supplied by these two things. Anterior rami of lower 6 thoracic nerves. Lower 6 means T7 to T12, okay? And the first lumbar one plus L1. Okay, so these are the nerve distribution of anterior abdominal wall. Now the dermatome. Now you must have know that what is dermatome. Dermatome is basically the distribution of skin which is supplied by a nerve root. Okay, like if you see this diagram, they have drawn that all this is T7. What does it mean? The T7 nerve root supplies this area. Okay, so T7 supplies this xiphoid area. Okay, upper xiphoid area. And so the dermatome of T7 is located in the epigastrium over the xiphoid process. The dermatome of T10. Now, where the T10? T10 is at the umbilicus. And that's a very important exam question. If they ask you that where what is the dermatome of umbilicus? Okay. And then there's a dermatome of third is important is the L1. So L1 supplies you the inguinal region and the pubic symphysis. Okay. So these three dermatomes are very important for exam purpose as well. And now see, this is T7. This is not thoracic vertebral level. This is the nerve root. So this is the interior rami of thoracic T7 nerve root. Okay. So you have to remember that previously we were discussing about trunk surface anatomy, and there we were discussing about the vertebral levels, that what vertebral levels, which thing occurs at which vertebral level. And now this is the dermatome. So this is the nerve roots. So T7, T10, and L1. These three nerve roots you have to remember, okay, for exam purpose. Now moving on to, first we have covered the skin. Now move on to the superficial fascia, okay. Now you all know the superficial fascia here in abdomen, it is divided into two layers. The first is the superficial and the second is deep. So superficial, it is a fatty layer. Now fatty layer is called fascia of Kemper. You just have to remember the names of these fascia, that the fatty layer FC, okay, you have to remember like this. Matlab fatty layer is Kemper, sorry. And then the deep membranous layer, which is Scarpa's. So MS, like membranous, is Scarpa's. So they can ask you in exam like this, what is the superficial fatty layer called? So they give you option of Kemper fascia, Scarpa fascia, Colles fascia. There are so many names of the fascia. So you have to correctly choose this fascia called. So fatty is F is Kemper and membranous is Scarpa. So just remember these names. The fatty layer is continuous with the superficial fat over the rest of body. The membranous layer is thin and it fades out laterally and above, where it becomes continuous with the superficial fascia of back and thorax. Okay, so it covers all around. And the membranous layer, basically it blends in the deep fascia of upper thigh, and in the perineum, this fascia is called as Colles fascia. So they can ask you like this, that in perineum, what is the membranous fascia called? So it is called Colles fascia in the perineum. Okay, so you just have to remember these names: Kemper fascia, Scarpa fascia, Colles fascia. Which fascia is called which? Okay, so Kemper is fatty, Scarpa is membranous, and Colles fascia is actually fascia and perineum. Okay, so only this thing is important in fascia. Coming to the third layer of anterior abdominal wall, which is the muscular layer. Okay, so we have 5 muscles in anterior abdominal wall. These are external oblique, internal oblique, transverse abdominis, rectus abdominis, and pyramidalis. Okay, pyramidalis is actually mostly it is absent in individuals. It's rarely present. So one by one, we'll discuss about each muscle. You just have know the basic understanding of these muscles. They usually don't ask about the origin and insertion of these muscles. They just ask you about the basic things. So external oblique muscle, because you have to know the origin and insertion to understand all these things. So that's why you have to read these things, okay? So external oblique muscle is a broad, thin muscular sheet, and it arises from outer surface of lower 8 ribs. See, this is the origin from all the ribs, okay? So the external oblique, it arises like this, and it goes to where it goes. The upper fibers, they go to the xiphoid process, and then all they goes to the, this is the linea alba, middle line, okay? And the lower fibers, they goes to the iliac crest, and then the pubic tubercle. Okay, so the fans out to be inserted into the xiphoid process starting from here, then the linea alba, then the pubic crest, pubic tubercle, and then the half of iliac crest. Okay, so if you see this diagram, you will see that how it arises and where it goes. Now, most of the fibers, they are inserted by means of a broad aponeurosis. Basically, the insertion of these muscles, they give all these muscles, they give the aponeurosis, and then both the sides muscles, because we have two external oblique muscles on both sides, okay? So both the muscles, they give aponeurosis, and then they join in the midline to form the linea alba, okay? So the fibers of two external oblique muscles meet in the midline and interdigitating to form the linea alba. So that's how the linea alba formed. Now, in the external oblique muscles, two things are important to remember, and that I have bold it, okay? So there is a triangular shaped effect in the external oblique aponeurosis. Where it lies immediately above and medial to the pubic tubercle, okay? Medial to the pubic tubercle. This is known as superficial inguinal ring. See here, this is a triangular defect in the external oblique aponeurosis, and it is medial to the pubic tubercle. So medial to the pubic tubercle. So there is the superficial inguinal ring. We will discuss in detail in the inguinal canal, because there the inguinal canal is basically from the deep ring and superficial inguinal ring. Okay. The next important thing is inguinal ligament. That the lower border of aponeurosis is folded backward on itself. See, these are the fibers. They fold back on itself, and then they form the inguinal ligament. So the inguinal ligament is formed from the external oblique aponeurosis. Okay, they can ask you like this, how the inguinal ligament is formed, or they can ask you which muscle forms the inguinal ligament. Okay, so that's the external oblique muscle. So these two things are important for external oblique. One is the inguinal ligament, and the next is the superficial inguinal ring. Okay, so move on to the linea alba. So I have discussed previously how it forms. The linea alba is a tendinous rough plate extend vertically from xiphoid process to the pubic symphysis, and it is formed of the fibers of all three muscles. All three, which muscles? The two oblique, external and internal, and the transverse abdominis muscles. So all three muscles, they basically give aponeurosis, and all the aponeurosis, they meet in the midline and they form linea alba. Okay, so it is interrupted by umbilicus. Like we already discussed it previously, the umbilicus is at the center of the linea alba. And what's the purpose? It transmits the umbilical vessels, like in the fetal life, the urachus, the vitelline duct during fetal life, but it closes soon after birth. Okay, so that was about the linea alba, and now we move on to our next muscle. So this is the internal oblique muscle, and it is also a broad, thin muscular sheet, and it lies deep to external oblique. Okay, above is the external oblique, then deep to it internal oblique, and deep to internal oblique will be the transverse abdominis. Okay, so these three are in the three layers. Okay, so most of its fibers, they run at right angles to those of external oblique. You remember the external oblique fibers, they were going like this in previous diagram. And now these internal oblique fibers, they are going like this. So these are at the right angle to the external oblique, most of the fibers. Okay, so from where it arises, the external oblique arising from the ribs, but the internal oblique is, you can remember, like it is opposite of the external oblique. What was the origin of that is the insertion of this. Okay, so it arises from below upwards, like from starting from this is the lumbar fascia, it arises. Then this is the iliac crest. Okay, this is also the origin point. And then see, this was the inguinal ligament, and inguinal ligament was made from the external oblique aponeurosis. Okay, so also the lateral two-third of inguinal ligament, the internal oblique is arising. So this is the three parts of the origin of internal oblique. And then the muscle is inserted. Now where the upper fibers, they goes to the ribs like this, and then the fibers go to the xiphoid process, same like the external oblique, because they have to form the linea alba. Okay, so they give the aponeurosis, they meet in the midline from the xiphoid, and they form the whole linea alba. Okay, and then the downwards to the pubic symphysis. Okay, so insertion point is the same. Xiphoid to till the pubic symphysis is the same insertion of all the three muscles. Okay, because all the three muscles, they have to give the aponeurosis, and they have to meet in the midline to form the linea alba. So insertion is almost same for all the three muscles. Okay, now one thing is important in this internal oblique as well. This is a conjoint tendon. Now what it is near their insertion, the lowest tendinous fibers, they are joined by similar fibers from transverse abdominis. Now these two muscles, transverse abdominis plus internal oblique, these two muscle fibers, they combine to form the conjoint tendon. We'll discuss it later in the inguinal canal as well. What is the significance of this conjoint tendon? Because these two fibers, they combine, and then they give strength to the inguinal canal. Okay, so that to prevent the inguinal hernia as well. So this strength of this conjoint tendon is very important. Okay, so this was a basic concept about internal oblique, and then move on to the transverse abdominis muscle. The name indicates it is the transverse, so the origin will be the transverse. Okay, so it will arise from upward till downward because its fibers are only running horizontally. So it's a thin sheet of muscle. It lies deep to internal oblique, I discussed previously, and its fibers only run horizontally. They're not going upward, downward, or obliquely. Okay, so it will arise from the deep surface of lower six costal cartilage. See the origin starting from here. They're arising from all these levels, like all the costal cartilage, then the lumbar fascia, then the iliac crest, and then the inguinal ligament. Okay, so its origin is starting from above till the downward, and insertion is the same, xiphoid, because all the fibers have to go only horizontally from xiphoid till the linea alba and the pubic symphysis. This is the insertion point of transverse abdominis. And again, the same thing, the lowest tendinous fibers, they join similar fibers from the internal oblique to form the conjoint tendon, which is fixed to the pubic crest and pectineal line. Okay, so conjoint tendon, its insertion point is pubic crest and pectineal line. Okay, so that was all about the transverse abdominis muscle. Okay, now this is a very important muscle, rectus abdominis. Now you all have be knowing that what is the rectus muscle. Rectus muscle, the rectus muscle is a long strap muscle. It extends along the whole length of the abdominal wall. Now rectus muscle basically arises from here, the pubic symphysis, and it goes upward. Okay, so origin is downward, insertion is upward into the costal cartilage. Basically, two things are important in this rectus muscle. It's first is the linea semilunaris. Now, what is the linea semilunaris? When this muscle contracts, its lateral margin forms a curved ridge. This is the lateral margin. Okay, so when the rectus abdominis it contracts, this margin can be palpated and can be seen. Okay, so this is called linea semilinaris. Okay. Now, the rectus abdominis muscle is divided into distinct segments by 3 transverse tendinous intersections. Now, these 3 tendinous intersections are important because they can ask you what was the level of these intersections. Now, these 3 levels, one at the level of xiphoid process, one at the level of umbilicus. See, this first is the xiphoid level, and xiphoid level, the second is the umbilicus level, and the third is midway between both these two. Okay, so this was the tendinous intersections of the rectus abdominis muscle. Okay, so basically this rectus abdominis is actually covered in the rectus sheath. Now, rectus sheath, it's a very important for your exam purpose, and you will get 1 or 2 questions from rectus sheath as well. Okay, so you have to remember this rectus sheath by heart. Now, what is the rectus sheath? Now, the rectus sheath, it's a long fibrous sheath and it encloses the rectus abdominis muscle and pyramidalis if present. Okay, so they can ask you about which muscles enclosed in the rectus sheath. So rectus abdominis is must, and pyramidalis because it is present in few individuals. Okay, it is not present in every individual. So the rectus sheath encloses these 2 muscles and what it contains. The contents are important. They can ask you what's included in the rectus sheath. So what will be included? The anterior rami of lower 6 thoracic nerves. We have discussed previously the cutaneous nerve supply, and we will discuss later the muscular nerve supply, because lower 6 thoracic nerves, these are supplying all these muscles, the abdominal wall muscles. Okay, so it has to enter through the rectus sheath and supply this rectus abdominis muscle. Okay, so you just have to have a basic knowledge that what it contains. So anterior rami of lower 6 thoracic nerves, they pierce this rectus sheath to supply the rectus muscle. Okay, and this was the nerve supply. They have to have a blood supply as well. So what blood supply this muscles has? Superior and inferior epigastric vessels and the lymph vessels as well. Okay, so they can ask you which nerve enters the rectus sheath or which nerve is present in the rectus sheath. They'll give you the levels, and so you can say lower 6 thoracic nerves, all the lower 6 thoracic, they enter the rectus sheath. And they can ask you which vessels they present in the rectus sheath. So superior and inferior epigastric vessels. Okay, so the most important in the rectus sheath is how it is formed. Now, rectus sheath, how it is formed? It is formed by the aponeurosis of 2 oblique muscles and the transverse. Like discussed previously, that all the 3 muscles, they give the aponeurosis and then they attach in the midline. Now, they give aponeurosis, and in the midline, they give the rectus sheath. Basically, the rectus sheath is formed from these aponeuroses. Okay, so all the 3 muscles, 2 oblique and transverse abdominis, they give aponeurosis, and this is how this rectus sheath is formed. Okay, so how it is formed? The aponeurosis of internal oblique on each side approaches the lateral border of rectus, and it divides into 2 lamina. Okay, like this is an internal oblique of aponeurosis, and it divides into 2. One passing deep to the rectus and other superficial. One goes up, one goes down, like both sides as well. Okay, so in the middle is the rectus muscle. Okay, and the aponeurosis of transverse abdominis supplies posterior to rectus, and that of external oblique will be anterior. The composition of rectus sheath, basically, I'll discuss it in the next slide. That's important because this composition of rectus sheath, it varies at different levels. Okay, so the first level is the above costal margin. Now you know what is the costal margin? That was the 10th costal cartilage. Okay, above the 10th costal cartilage, composition is different of anterior wall and posterior wall of rectus sheath. Basically, it is. Then from the costal margin till arcuate line, I'll discuss it later. Arcuate line. That what is arcuate line? You just remember it, a landmark. Okay. So from costal margin till arcuate line, that composition is different, and then below arcuate line, it is different. Okay, so you have to remember these three levels. It's very, very important. They can ask you, okay, from the above the costal arcuate line, what is the composition of anterior wall, or what is the composition of posterior wall? See this diagram, then I will you understand from this diagram. Okay, so these three are the levels which we discussed previously. This is above costal margin. Okay, so above costal margin, what happens? See, this is the muscle, rectus muscle. Okay, this blue is the rectus muscle, and what's above the rectus muscle is the aponeurosis of external oblique. Okay, so above the costal margin, the aponeurosis of external oblique is only present. So only external oblique aponeurosis is present in anterior layer. Okay, so it is going anteriorly. See, what is posterior to the rectus muscle? Rectus muscle, there is no posterior layer of rectus sheath. The rectus muscle is directly on these ribs, the ribs and the costal cartilage. Okay, so above costal margin, I'll go to the previous slide. See this. Above costal margin, anterior wall is made of external oblique aponeurosis, and posterior wall is none. Means there is no sheath of posterior wall. Okay, no posterior layer, you can say. The rectus muscle is directly on the rib bones and costal cartilage. Okay, so that was the first level, is the above costal margin. Okay, so this is important, this costal margin, from costal margin till arcuate line. Okay, you remember this as a landmark. I'll discuss in next slide what is arcuate line. Okay, you just remember like this. Now at this level, see, you are seeing this is as the rectus muscle. Okay, now what happens with the aponeurosis? See, this is the external oblique, then the internal oblique, and the transverse muscle. Okay, these are three muscles are layer by layer present. External oblique is actually, you can remember that external oblique aponeurosis always go anterior. Okay, see, it goes anterior, then the internal oblique. We read it previously that internal oblique, when it goes near the rectus muscle, it divides into two lamina. First goes anterior, and the second lamina it goes posterior. Okay, so internal oblique, so external oblique was always anterior, internal oblique both options, anterior as well posterior. Okay, now this is the transverse muscle. So transverse muscle is also going posterior. So this is a very easy to understand that above muscle goes anterior, the below muscle it goes posterior, and the middle it gives two layers. Okay, one anterior and one posterior. Okay, so this is from the costal margin till arcuate line. Now move on to the previous slide. Now read this table. From costal margin till arcuate line, what is the composition of anterior wall of rectus sheath? So it is formed from the external oblique aponeurosis, and it is formed from the internal oblique aponeurosis. Okay, I discussed previously external oblique and internal oblique. And what is formed from the posterior wall? Posterior wall is formed from the internal oblique and the transverse abdominis muscle aponeurosis, basically. Okay, right? Understand? So this is very important. They can ask you that above arcuate line, posterior wall aponeurosis is made of which muscles? So you must remember this external, the anterior wall from external, internal, posterior wall from internal and transverse. Okay. So the next point, the next level is the below arcuate line. So it's a very easy as well. In below arcuate line, all the three muscles. See, this is the external oblique, this is the internal oblique, this is the transverse. All three muscle aponeurosis, it goes anterior to the muscle. Okay, 1, 2, and 3. All three goes anterior. And the rectus muscle, this is the rectus muscle. Where it lies, there is no posterior layer of rectus sheath, but it lies directly on the fascia transversalis. Fascia is everywhere. Fascia transversalis has to be everywhere. Okay. So there is no posterior layer of rectus sheath. If they ask you what is the composition of posterior layer of rectus sheath, so there is no actually posterior layer. It is just posteriorly. You can say that it is fascia transversalis is only present, but there is no rectus sheath layer. Okay, so move on back to the table, and here below arcuate line, all the three muscles, they are in the interior wall, external, internal, transversus, and in posterior wall, like none, like the above costal margin. So it is very easy to remember. You have to remember this, that above costal margin, below arcuate line, there is no posterior layer. Okay, and only posterior layer is present in the in this in these points, costal margin till arcuate line. Okay, so this is a very important composition of rectus sheath. They usually ask you about the composition of rectus sheath, the layers of rectus sheath, which layer is formed from which muscle, anterior, posterior, and what formed from the these layers. Okay, so arcuate line, coming to the arcuate line, what is actually arcuate line? So basically, where the aponeurosis forming the posterior wall pass in front of rectus. Okay, when all the aponeurosis, see, we see at the third level. So at the level of anterior superior iliac spine, posterior wall has a free curved lower border. So arcuate line is basically is nothing but, you can say, this is the end point of posterior layer. Okay, we discussed now that posterior layer was only present from costal margin till arcuate. Okay, so where the posterior layer happened is a free curve, and any important for this, but this level is important for the rectus sheath purpose, because below this level, below arcuate line, if you remember like this, that arcuate line is the end point of posterior layer. So you can remember that, you can say that if they ask below the arcuate line, so there is no posterior layer. Okay, so at this level, so this arcuate line is at the level of anterior superior iliac spine, ASIS. Okay, they can ask you like this: what is at the arcuate line is at which level? So it is at the anterior superior iliac spine level. And the second significance of this level is at the site, inferior epigastric vessels. They enter the rectus sheath and they pass upward to anastomose with superior epigastric vessels. Like I told you previously that which nerves and which vessels enter the rectus sheath. Okay, so the inferior epigastric vessels, they enter the rectus sheath at this level, means arcuate line. Okay, so this is an important level as well, and you have to remember the rectus sheath, very important part of this MRCOG anatomy module. Okay, so this is just a brief overview of all the muscles of anterior abdominal wall. We have discussed it in detail. So we will just name action. L1 only mental system, only stress now. You know, Hello, am I audible? Am I audible now? There was, I think, some internet problem. Okay, fine, good. So can I tell me, okay, कहाँ तक आप लोगों को आवाज आई? I'll go to the slide. So we were discussing about the muscles. Okay. Okay, if you have, if you think any कोई voice interruption, so you can tell me. Okay. So let's start again. I was discussing about these muscles. Okay. So only thing you have to remember from these muscles, you have to know the nerve supply, which is all the muscles are actually supplied by the lower six thoracic and the L1 nerves. Only the rectus is on supplied by only lower six thoracic nerves, and pyramidalis is present is the 12th thoracic nerve, which is called the subcostal nerve. Okay. And then the muscle actions. Actually, all the actions are all the muscles are doing the same action. They support the abdominal contents, they assist in flexion and rotation of trunk, and they assist in forced expiration. Okay, like whenever you have to increase the intra-abdominal pressure, like in micturition, defecation, parturition, and vomiting. So then these. So the same is the internal oblique, same. It is the compressed abdominal contents. It flexes the vertebral column. So that's just a different and the accessory muscle of expiration. And pyramidalis, if it is present, it tenses the linea alba, and it's usually absent in majority of people. Okay. So that was all about the layers of the abdominal wall, the skin, the fascia, and the muscles. And then we will just give a brief introduction of the blood supply of anterior abdominal wall. Okay, so blood supply is divided into two parts, two things. The superficial arteries, they are the deep arteries. Okay, so superficial arteries are the superficial circumflex, superficial epigastric artery. And the deep arteries, we have superior epigastric, inferior epigastric, and deep circumflex vessels. Okay, I'll discuss it in later slide. Like, we'll discuss it one by one. Okay, so this is the superior epigastric artery. These deep arteries are actually very important for exam purpose as well. So superior epigastric artery, here it is. Superior epigastric artery, it is a branch of internal thoracic artery. So it supplies the upper symphysis, like the central abdominal wall, and it anastomosis with the inferior epigastric artery. This is the inferior epigastric artery going up, and they both anastomosis. Okay. So the next is the inferior epigastric artery. It is a now this is the inferior epigastric artery. It is a branch of external iliac artery. Okay. This is a very important artery for our exam purpose as well. So it supplies the lower central part, same anastomose with the superior epigastric artery. And then there's a deep circumflex artery. It is also a branch of external iliac artery. See, here it is the deep circumflex. It is also a branch of external iliac artery and it supplies the lateral. So it is supplying the lateral part of abdominal wall. Okay. So these are the three deep arteries, and then we'll be having these three superficial arteries. Okay. So the superficial circumflex artery. The name indicates it is the superficial circumflex. So this is these are the branches of femoral artery. Okay, these two, these are branches of femoral artery. So superficial circumflex, it supplies the superficial abdominal wall of inguinal region and anterior thigh. Okay, so this is the inguinal area. It supplies by the superficial circumflex artery, and then the superficial epigastric artery. This is a branch of femoral artery and it supplies the superficial abdominal wall of pubic and inferior umbilical area. So this is the deep circumflex artery. Oh, no deep, superficial epigastric इधर है, ठीक है. Okay, so these are the
Ma'am,
two.
slides not visible.
Hello?
Ma'am, slides are not visible.
Invisible. Okay. It was actually ended before. Hmm. Okay, now it's visible.
Yes, ma'am.
ठीक है. Acha, I was here. It was just a table I was discussing. So it's nothing important in this. And the blood supply, I have discussed with you that there are the two types of blood supply. There is the superficial arteries and then the deep arteries. Okay. So in superficial arteries, two arteries are important: superficial circumflex arteries and superficial epigastric artery. Okay. And in the deep arteries, superior epigastric, inferior epigastric, and deep circumflex vessels. So that was I was telling you about the blood supply, that these are the three very important blood supply of anterior abdominal wall. This is the superior epigastric artery. See, this is the superior epigastric artery. It arises from internal thoracic artery, okay? And it goes downward and it anastomoses with the inferior epigastric artery, okay? So inferior epigastric artery is actually a branch of, it goes from up below to upward. It is a branch of external iliac artery. So these two arteries are very, very important. You have to remember that what is the branch, superior epigastric is a branch of which artery. So superior epigastric is a branch of internal thoracic and inferior epigastric is a branch of external iliac artery, okay? So it supplies the superior valley, supply the upper central part, and inferior epigastric, it supplies the lower central part of wall, okay? So there's another branch of external iliac artery, it's the deep circumflex iliac artery. Okay, so this is the deep circumflex iliac artery, and it supplies the lateral part of abdominal wall. Okay, so these three arteries are important in supplying of the entire abdominal wall. And then these are the superficial arteries. So superficial arteries are branches of femoral artery. You remember it just like this. And the deep arteries were the branches of one was the internal thoracic artery, and two arteries were from the external iliac artery. So because external iliac is actually deep, so they will give the deep arteries, and the femoral artery is superficial, so it gives you superficial branches. So these two branches, superficial circumflex and superficial epigastric. So in exam, whenever there is option like superior epigastric, superficial epigastric, you have to see it very correctly, because you can see it like this is written as superior epigastric. So these are very little bit confusing. Like superior epigastric is the deep artery, okay? It is a branch of internal thoracic. And superficial epigastric artery, it's the name indicates these are superficial. So you can remember it like this. Both the superficial branches arteries are branch of femoral artery, okay? And superior and inferior, they were the branches of deep arteries. So deep was the internal thoracic and external iliac artery, okay? You just have to remember this is only this part is that what is the branch of which one. Okay, so there are a few other branches of which were supplying the abdominal wall, the lower two posterior intercostal arteries, and the branches of descending thoracic aorta. There are four lumbar arteries as well. Okay, they pass forward between the muscle layers and they supply the lateral part of abdominal wall. So there are multiple layers, multiple arteries which supply this entire abdominal wall. But you have to remember the superficial and deep arteries. Okay, so 2, 3 from both the groups. Then next, this is very important, the clinical significance of inferior epigastric artery. Okay, I told you previously that this artery is very important for our exam as well. Inferior epigastric artery, uh, it's a branch of external iliac. Okay, so it is important to identify the inferior epigastric vessels before inserting the lateral ports at laparoscopy. Okay, when you enter the abdomen, and the lateral ports, they are to be entered later. So you have to be very vigilant about the ligation of inferior epigastric vessels. Okay, so insertion of port trocar through this vessel will result in major hemorrhage. And these vessels, how you can identify in laparoscopy? Okay, where is the inferior epigastric vessels? When you enter into the when you enter the abdomen and you visualize the abdominal cavity, you see these vessels are lateral to the medial umbilical ligaments. Okay, and these umbilical ligaments, they are clearly seen at laparoscopy. I will discuss it in next lecture. There are few in peritoneal cavity actually. There are few very important ligaments. One is the median umbilical ligament. Then there are the medial umbilical ligaments and the lateral umbilical ligaments. Okay, so you just remember it here that these vessels, they are lateral to medial umbilical ligaments. So you have to be very vigilant by inserting your lateral ports. Okay, so that's the very important significance of this inferior epigastric artery. Okay, now the venous supply. You just have a basic knowledge of these blood supply. If you write anywhere the arterial supply, you can only by seeing the arterial supply, you can write the venous supply as well as the lymphatic supply, because all the arteries, all the veins, they correspond to the same arteries. Okay, very few there are difference in the names of the veins. Okay, so in the venous supply, again there are the superficial veins because they were the superficial arteries. Okay, so there are the superficial veins and the deep veins. Now superficial veins, they form a network that radiates out from the umbilicus. So above means above the umbilicus, they drain into the axillary vein via the lateral thoracic vein. See, you remember like previously the lateral thoracic artery was internal thoracic artery. So above the umbilicus, they drain into the axillary vein and below into the femoral vein. See, femoral is superficial. Okay, so femoral artery is superficial, so femoral vein is also superficial. Okay, so but you have to remember that this is the umbilicus, and above they goes to the axillary vein and below the goes to the femoral vein. Okay, so these two names you have to remember. And few small veins, they are the paraumbilical veins. They also have very important significance. They connect the network through the umbilicus and along the ligamentum teres to the portal vein. So this is the network of the portosystemic venous anastomosis. So whenever there is portal vein hypertension or portal vein obstruction, you can say, so these paraumbilical veins, they dilate. Okay, and then they form like this, which you already have known, that the caput medusae like picture. Okay, so you have to remember these venous supply. These was the superficial veins and then the deep veins. Now the deep veins are all exactly the names of the arteries, like superior epigastric vein, then the inferior epigastric vein, and the deep circumflex iliac veins. These three arteries and these three veins. Okay, and then they drain into the same arteries as well, like internal thoracic vein and the external iliac veins. Okay, So deep veins have exactly the same name as of the arteries. And then the posterior intercostal, because there were the posterior intercostal arteries as well. So posterior intercostal veins, they drain into azygous veins. The lumbar veins, they drain into inferior vena cava, and lumbar arteries were directly the branches from aorta. So the hello, do you have any question? Okay, there's some interruption. Okay, kindly everyone, please mute your mics. Okay. So I was saying the posterior intercostal veins drain into azygous vein, and the lumbar veins they drain into inferior vena cava. Okay, so these are the venous and arterial blood supply of anterior abdominal wall. Okay, that I have discussed previously, that in case of portal vein obstruction, superficial veins around umbilicus and the paraumbilical veins they grossly distended, and the distended subcutaneous veins radiate out from the umbilicus, and in severe cases it is called as caput medusae. Okay, so this will be the picture of the caput medusae in portal vein obstruction, and they can ask you, this is a recall question, at which veins are dilated. So these are the paraumbilical veins, they are dilated. Okay, so next is the lymphatic drainage of anterior abdominal wall. Okay, so lymphatic drainage is very similar to the venous supply as well. Okay, so where I told you now the superficial, again the superficial lymph vessels and then the deep lymph vessels. The superficial lymph vessels is above the umbilicus, below the umbilicus is different. So this is the cutoff point, this is umbilicus, and above umbilicus they goes to the anterior axillary lymph nodes. Like the venous supply, they goes to the axillary vein. Okay, now below umbilicus, they goes to the superficial inguinal nodes, and there it was the femoral nerve, because the femoral nodes they also goes to the superficial inguinal nodes. So you can remember it like this. And then the deep lymph vessels, every deep artery, veins, and lymph vessels, they are the same. They follow the arteries, veins, and they are just the same. So these deep lymph vessels, they follow the arteries, and then they drain into internal thoracic lymph nodes, and then the external iliac, posterior mediastinal, and para-aortic lymph nodes. Okay, so this was all about the blood supply of anterior abdominal wall. Okay, blood supply, venous supply, lymphatic drainage of wall. Now move on to the inguinal region. Now it's a very important area, and often basically anterior abdominal wall, and there in exam you can get few questions from this area as well. So you have to remember this area as well. It's a little bit uh, difficult, you have to remember it. So inguinal ligament is actually easy. What is called, it's also called as a ligament of Foucault, and it runs from anterior superior iliac spine to pubic tubercle. And I discussed you previously that it is formed from the aponeurosis of external oblique. Okay, so that's the important thing about inguinal ligament. Now inguinal canal, actually it's very important. Inguinal canal, it is an oblique passage through which the lower part of our abdominal wall, and it transmits. Now what does it transmit means, what does it contains? They can ask you like this. It transmits the round ligament of uterus in females, and in males with the spermatic cord, and the ilioinguinal nerve. Now this is a very very important exam question as well. What what ilioinguinal nerve, they can ask you that which nerve traverses the inguinal canal like this, or they can ask you what which contents are present in the inguinal canal. So these two things are very important: the round ligament and ilioinguinal nerve. It enters the inguinal canal. Okay, so in males it allows spermatic cord to pass to and from the testis to the abdomen, and in females it allows a round ligament. So in males it will be the spermatic cord, females it will be the round ligament. Okay, so this inguinal canal is approximately 3.8 centimeter long. It lies parallel and above the inguinal ligament. So ligament is a separate thing and canal is a different thing. Okay, so it runs from internal ring to external ring. Internal means deep, so deep to superficial ring. And we discussed it previously. Where is the superficial ring? The superficial ring was in the external oblique. Okay, so these are the important points of the two rings: deep inguinal ring and superficial inguinal ring. The differences as well. You can will be discussing it later. So these two rings are important. You have to remember these things. So deep inguinal ring and a superficial. It is just an oval opening. It's a triangular defect. Now deep is present in, it's a deep, so it will be present in the deepest muscle. So it is in the fascia transversalis. And the superficial we have discussed previously, it is in the external oblique, because external is oblique is superior, and transverse abdominis muscle is posterior. Okay, so deep ring is present in fascia transversalis and superficial ring in the external oblique aponeurosis. Now, what are the landmarks of these rings? Okay, you have to remember that the deep ring, it lies midpoint of inguinal ligament. Okay, and superficial ring, it lies above and medial to the pubic tubercle. Now, this is important landmark for the inguinal hernias as well. Here we are discussing that it is medial to the pubic tubercle. It's a superficial ring. Okay. Now we'll discuss it later about the femoral triangle and femoral hernia. So there it will be different thing. Now the deep ring. There are some relations of the deep ring. Medially, it is demarcated by inferior epigastric vessels. Now this is a deep ring, and medially here it is the inferior epigastric vessels. Okay, and it is 1.26 centimeter above femoral artery. Okay, so the inferior epigastric relation is important. What is medial, or they can ask you inferior epigastric vessels related to the deep inguinal ring, whether it is lateral or medial. Okay, so medial is the inferior epigastric vessels, medial to this deep inguinal ring. And the last thing is that margin, they give attachment to the internal spermatic fascia through the, from the deep ring they goes to the superficial inguinal ring. Okay, so they traverses this canal, and through passing this canal they take up some layers of water. So deep is the deep first, from going through the deep inguinal ring, they take up the this layer, internal spermatic fascia. Okay, and then they, when they pass through the superficial inguinal ring, then they will be having this external spermatic fascia. These are the couplings of spermatic cord by passing through this inguinal canal. Basically, inguinal canal, it lies from deep ring to superficial ring. Okay, now you have to remember two things. First, that from where it is present, it is deep is in the fascia transversalis, superficial is in external oblique aponeurosis. Okay, and the landmark of this ring, it is in the midpoint of inguinal ligament, and it is the superficial is above and medial to the pubic tubercle. Okay, and deep ring is also related to the inferior epigastric vessels. These are medial to the deep ring. Okay, and then the spermatic fascia, they are giving the lining. The deep gives to the internal spermatic fascia, and the superficial gives to the, so superficial will be giving the layer later on. So it will be given the external spermatic fascia. Okay, So these are the few differences and few important points related to these rings. Okay, they can ask you these points, so you have to remember these as well. Okay, so this is also a diagram. Okay, and they are giving you the contents of inguinal canal, like spermatic cord, round ligament, and only the nerve is inguinal nerve passes, and they have the blood and lymphatic vessels as well. Okay, so now the walls of inguinal canal. This is actually they do not. Previously, no question comes from these walls of inguinal canal, but you can just read this. Okay, so basically the interior wall. So what is interior to the inguinal canal? It was the external oblique, it was coming downward. External oblique, it comes downward and then it folds backwards, okay, to form the inguinal ligament. So inguinal canal will be having the external oblique anteriorly as well as in the inferior wall. So inferior wall, they can say inguinal ligament, but it is also the external oblique aponeurosis basically that gives to the inguinal ligament. So you can remember it like this, that external oblique, it comes downwards and it makes the anterior wall of inguinal canal and also the inferior wall in the form of inguinal ligament. Okay. Or anterior wall may the next will be also the internal oblique as well, and in posterior wall as well the conjoint tendon. So posteriorly, so now the anteriorly is the external oblique. So all the rest of the muscles will be posteriorly. So conjoint tendon means internal and transverse abdominis as well. Okay. So conjoint tendon and the fascia transversalis. So basically this is the conjoint tendon. It is required for the strength of posterior wall. If conjoint tendon is weak, the posterior wall is weak. Okay, then there is a chances of inguinal hernia as well. So this is important. Posterior wall is made by the conjoint tendon, and superiorly as well the internal oblique transverse. Basically, all these muscles are forming the inguinal canal. You can just rough idea of all the muscles. Okay, so you don't need to remember these each and everything. What is making the anterior, posterior, just have a basic idea that external oblique is coming anteriorly and downward. So anterior inferior wall, and then the posteriorly there's a conjoint tendon. So that's in significance of conjoint tendon as well. Okay, so that's important. Okay, now move on to the spermatic cord. We're discussing what passes through the inguinal canal. So spermatic cord is actually it's a collection of structures that pass through the inguinal canal to and from the testis. It begins at the deep inguinal ring, lateral to the inferior epigastric artery, and ends at the testis. See, it is lateral to the inferior epigastric artery because epigastric artery is here medially and lateral is the deep ring. Okay, so the deep ring is lateral and epigastric artery is medial. Okay, and what it comprises is comprised of three facial layers. See the external spermatic fascia, cremasteric fascia, internal. We discussed it previously. External spermatic fascia will be formed by the external oblique aponeurosis, and that was by the when it passes through the superficial ring. Okay, and cremasteric fascia is formed by internal oblique, and internal spermatic is from the transversalis fascia. And transversalis fascia, what was there? That was the deep ring. Okay, so the spermatic cord, when it enters the deep ring, it takes the internal spermatic fascia, and when it goes through the superficial ring, it takes up the external spermatic fascia. Okay, so layer by layer, you can remember it like this, that all the three basically these are the two muscles and this is the fascia. Transversalis fascia is giving the spermatic fascia to the spermatic cord. Okay, so this was about the spermatic cord and what's included in all the spermatic cord, what's inside. This is important exam question as well, that they can ask you, okay, which structures pass through the spermatic cord. So basically spermatic cord, what includes? It includes the vas deferens, okay, and the main structure is actually the vas deferens. It goes to the testis. Okay, so there would be the artery, the veins, the lymph vessels, the nerves. Okay, these four things are important. So testicular artery, then the testicular veins means pampiniform plexus. See, this is the pampiniform plexus. This is the testicular artery. This was the vas deferens, okay? And some lymph vessels, the autonomic nerves, and then the remains of processus vaginalis. We don't have to go to the detail, but we will discuss it in the embryology section as well, okay? So the remains of processus vaginalis, if it does not obliterate in the fetal life for children, then the children will have the congenital hernia of the indirect inguinal hernia, okay? So the remains of processus vaginalis, it actually obliterates in the spermatic cord. And then there is a nerve that's important of the genital branch of genitofemoral nerve, and it supplies the cremaster muscle. So cremaster muscle is in the spermatic cord. So the nerve supplying this muscle is the genital branch of genitofemoral nerve. So that's the important nerve, and these are the vas deferens and few artery, vein, lymph vessels. So everything that drains and that supplies this vas deferens is present in this spermatic cord. Okay, so that's the important structures you have to remember. Now, ilioinguinal nerve. Actually, this nerve is very important. It's related to our abdominal wall, so I think I should discuss it now. So, from where it arises, it is the L1 level. From the anterior primary ramus of L1, the ilioinguinal nerve emerges from the lateral border of psoas major. Okay, it crosses the quadratus lumborum. It perforates the transverse abdominis close to anterior part of iliac crest and runs the neurovascular plane until it pierces the internal oblique. At which point it enters the inguinal canal. Okay, so that was, we discussed previously that which nerve was present in the inguinal canal. So that was the ilioinguinal nerve only, basically, and it emerged through the superficial inguinal ring. Okay, distributed where it is distributed to skin on the medial aspect of thigh as well as the skin covering the mons pubis and labium. So basically, it supplies the area of thigh and pubis. Also supplies the fibers of internal oblique, transverse abdominis, which contribute to the conjoint tendon. So basically, it's supplying the internal oblique and transverse abdominis. So these two muscles, they form the conjoint tendon. And I told you previously that conjoint tendon makes the posterior wall of inguinal canal. Okay. So if the damage to the ilioinguinal nerve, then these two muscles will be weakened. It means conjoint tendon is weak. So it weakens the conjoint tendon and it potentially inducing the development of a direct hernia. I will tell you in detail what are the indirect and what is the direct hernia. So that's the important thing to remember in inguinal canal relations as well. That conjoint tendon was making the posterior wall of inguinal canal. Okay, and it is supplied by the L1 nerve root. So if this nerve root damage, it weakens these muscles, this tendon, and it leads to the development of direct hernia. Okay, so this is all about the inguinal canal. Now move on to a few important triangles, and you, I don't think so. They ask you about the relations of this triangle, but contents and everything are very important. So femoral triangle. So basically femoral triangle is located where it is located. So there are the few relations of this. Lateral is the sartorius, medial is the adductor longus. Floor is made of iliacus and psoas. Okay. And what is superior to it? The inguinal ligament. Okay, so it is behind the inguinal ligament is present actually the femoral triangle. And roof is made of the fascia, the great saphenous vein, lymph vessels, and fascia lata. Okay, so this is the femoral triangle, and triangle means what it includes. What are the contents? The contents will be the femoral nerve, artery, vein, and a few inguinal lymph nodes. Okay, so this was the femoral triangle, femoral sheath. This is very important. You have to remember this slide by heart. Okay. So femoral sheath is actually derives from extraperitoneal intra-abdominal fascia Anteriorly, the sheath is from the transversalis fascia, and posteriorly from the iliacus fascia. We discussed that femoral triangle, the posterior wall was the posteriorly was the iliacus muscle. Okay, so the femoral sheath is formed from these two fascia, transversalis anteriorly and iliacus posteriorly. And what it contains, that's very important. In the femoral sheath, this actually I made a femoral sheath. Okay, in femoral sheath, one thing is femoral canal. Okay, then it is the femoral vein, and then is the femoral artery. See, the femoral nerve, it is not inside the femoral sheath. Okay, so it does not contain the femoral nerve. You must have to remember that femoral sheath does not contain the nerve. Nerve is free from sheath. Okay, so
Ma'am, voice not coming.
if you can am I audible to everyone now?
Yes, ma'am.
Okay. Or screen. Okay, my screen is visible to all of you?
No, ma'am.
No. Mm, okay, now it's visible, right?
Yes, ma'am. Yes, ma'am.
Let's discuss it again. It's a very, very important thing. Femoral sheath. Okay, so femoral sheath, you have to remember it by heart. What from which fascia it is made? It is made from transversalis and iliacus fascia, and what does it contains? Okay, so these three things are important. It contains the femoral canal, femoral vein, and artery. Okay, it does not contain nerve. Nerve is free of any sheath. Okay, so the relations where it is located, like canal is medial, then the femoral vein, then artery, and then the nerve. So if they ask you what is the relation of vein, artery, and nerve, so you can remember it like this. It is a van. From medial to lateral, you have to remember them. Okay. The vein is medial, then the artery, then the nerve. Okay. And the canal is most medial. So you can say the most medial thing is femoral canal, then the vein, artery, and nerve. Okay. So these three things in the femoral sheath, but the nerve does not include in the femoral sheath. Okay. So that's a very, very important relation and contents as well. Okay. So this thing you can see it on this diagram. Like, see, this is the femoral triangle. We have seen that femoral triangle contains all the nerves. Okay. All the nerve, artery, and vein. See, this is the nerve. So nerve is the most lateral thing. Okay. So it does not contains into the femoral sheath. So in femoral sheath, what contains the three things: artery, vein, and canal. Okay, so this is the artery, and then the vein, and this is the canal. And in canal, basically the inguinal nodes are present in femoral canal, and few lymph vessels as well. Okay, so You have to remember that nerve is always lateral. Okay, in van, this is, you have to remember, you can see the canal as well. So canal is always medial and nerve is always lateral, and it not included in the femoral sheath, but it is included in the femoral triangle. Okay, so if you see that this is a femoral triangle, you can say the nerve, artery, and vein is present in the femoral triangle. But in femoral sheath, only artery, vein, and canal. So their relations are important. What is medial? The most medial thing is canal, and then the vein, artery, and nerve. Okay, so this is important relations for the femoral triangle and femoral canal. Now, another thing is femoral ring. Basically, femoral ring is nothing, just this is the entrance to femoral canal. So it is the, like this is a canal, so this is the ring. So it is the entrance of the femoral canal. It is oval shape. It's larger in females. Diameter is 1.25 centimeter. And what does it contains? Which contains the femoral canal. So femoral canal, I told you that it contains the fat and lymph node and lymph vessels. So these lymph nodes are called as Clockett's lymph nodes. Okay. So femoral ring is basically nothing, just the femoral canal opening to the femoral canal. Now there are the few relations of femoral ring as well. So anteriorly, the inguinal ligament, because everything is situated posterior to the, we discussed it in femoral triangle as well. It is uh, the femoral triangle and femoral ring is posterior to the inguinal ligament. Okay. Now posterior to this ring it will be the pectineus muscle, pectineus fascia, and medial it is the lacunar ligament, and lateral. See lateral, what we should be lateral to the canal, it will be the femoral vein. Okay, so there it was canal, and then there it was vein, and then artery, and then the nerve is outside. Okay, so these relations you have to remember it by heart. Okay, these are important relations. What does it contain? So femoral ring contains what the canal contains. Okay, so femoral canal is all only contain the lymph node and some lymph vessels. Okay, there is no artery, vein, or nerve in the femoral canal. Okay, so you have to just see it very clearly. What are they asking? They're asking you about femoral sheath, or they are asking you about femoral canal. Okay, so that's the important thing. But it includes femoral canal and what is inside the femoral sheath. This is another triangle of Hasselbach's triangle. Actually, the clinically it is important. It is a space bounded by laterally will be the inferior epigastric artery. So basically, if you see, this is the muscle, rectus abdominis muscle. Okay, so and here the inguinal ligament is going like this. Inguinal ligament goes from anterior spiralic spine to pubic tubercle. Okay, so rectus abdominis arises from this. Now the inferior epigastric vessels, they go like this. Okay, so if you see this, this is a triangle, and what does it? How it is bounded laterally by this vessels, inferior epigastric artery, medially the rectus abdominis, and inferiorly is the inguinal ligament. Okay, so it is also known as inguinal triangle as well, and the direct site of direct inguinal hernia. This is the site of direct inguinal hernia. Okay, so this was all about the abdominal wall, and now the clinical significance of this abdominal wall. Why we have read all this abdominal wall? What is the layers? Because clinically it is important, because there is abdominal hernia. There are so many cases of abdominal hernia. Okay, so hernia is actually the protrusion of part of abdominal contents beyond the normal confines of abdominal wall. There's hernia of everywhere. The hernia is called whenever there's protrusion of the contents. Okay, so hernia will be having the three parts. There's the sac, and then the contents of sac, and the coverings of sac. So the hernial sac is a pouch of peritoneum, and it will be having a neck and a body, and it may consist of any structure found within the abdominal cavity. Okay, whenever there's abdominal hernia, means the abdominal contents are moving out. So contents are vary according to the type of hernia. Okay, so these three are actually important. I have given you in a tabulated form. Okay, so you have to remember this much information about the hernia. So Indirect, we are having the indirect, direct, and femoral hernia. Okay. What is actually the indirect? Indirect means the hernia is through the inguinal canal. See, this is the inguinal canal from deep ring to superficial ring. So if the hernia is from the abdominal cavity, it goes to the deep ring, and then it goes to the superficial ring, and then it goes to like in the scrotum. Also, this is the indirect because it is an indirect passage. Okay, so this is called the indirect. Direct means directly through the wall. Okay, it will be straight, and the femoral hernia is only in the femoral triangle. Okay, so femoral canal, sorry. So indirect hernia, most common form of hernia. Okay, so most common, and it is congenital in origin, and so it will be present in children and young adults. Okay, so the hernial sac is the remains of process vaginalis. I discussed previously that there are the few remains of process vaginalis. It has to be obliterated. Okay, so if it does not obliterate, then it enters this, the sac enters through the inguinal canal, through the deep ring, lateral to the inferior epigastric vessels. Okay, you remember the relation of deep inguinal ring to the inferior epigastric vessels. I told you that this is the deep ring, and the here is the epigastric vessels. Okay, so the hernial sac enters through the deep ring. So the hernial sac will be the lateral to the inferior epigastric vessels. That's the important landmark for the indirect hernia. The hernial sac may extend through the superficial inguinal ring above and medial to the pubic tubercle. Again, the locations of these rings is very, very important. You have to remember these by heart. Now, where is the deep inguinal ring and where is the superficial? See, they have told you that if hernial sac extend through the deep, through the superficial, okay, then it will go above and medial to the pubic tubercle. That was the location of superficial inguinal ring. Okay, so this is actually the indirect hernia. It is congenital and it has the remains of process vaginalis. Okay, so because that was not obliterated, so it goes from the deep ring to the superficial ring, and it can go up till the scrotum. So that will be the complete indirect inguinal hernia, and there's the incomplete also. Okay. Then there is the direct inguinal hernia. Direct has, it is less common. It makes up only 15%. It is common in old men with weak abdominal muscles. See, weak abdominal muscles. Why weak abdominal muscles they causing hernia? We have discussed it previously, the importance of conjoint tendon. Okay, so conjoint tendon was made by the two muscles, internal oblique and the transverse abdominis. So that's the reason when the conjoint tendon is weakened, so the muscles weak, and then the inguinal canal posterior wall was weak. So that's the reason it is common in the older man with weak abdominal muscles. So the hernial sac bulges forward through the posterior wall of inguinal canal. See, through the posterior wall. So that means posterior wall is weakened. Okay, and this is the medial to the inferior epigastric vessels. So now you see, it is the medial to the inferior epigastric vessels. And so that was the deep, through the deep inguinal ring, it was the herniated, and that is lateral to inferior epigastric vessels. Okay, so this was the direct and indirect inguinal hernia. And see, this is in this diagram. See, this is black arrow. This is the neck of hernia. Through this, the contents are herniated. Okay, and then these contents they enter the inguinal canal. So this is the deep inguinal ring, location of deep inguinal ring. It enters the inguinal canal, and here it is the superficial inguinal ring, and it can go up till here, or it can go here as well. In this diagram, it is the hernial sac is up till this. Okay, so this is the diagram of indirect inguinal hernia. And what is the direct inguinal hernia? See, this is direct means this, all this posterior wall, this is weakened, so directly it is protruding. Okay, so this is the direct inguinal hernia. See the location of inferior epigastric artery. So direct hernia will be medial to this artery. Indirect hernia will be lateral to this artery. Okay, so this is the herniated deep ring and this is artery. Okay, so this is an important relation of hernia with the inferior epigastric artery. Okay, so I have not discussed femoral hernia. So basically, femoral hernia, it is a protrusion of abdominal peritoneum through the femoral canal to form the hernial sac. It is actually common in women and the neck of sac. Now, this is important just below and lateral to the pubic tubercle. So, neck of sac location. It is below and lateral to pubic tubercle, and here in the indirect hernia, it was medial to the above and medial to the pubic tubercle. This is the differentiating point between these two hernia. Okay, so in examination, if we see that neck of hernia is medial to the pubic tubercle, then it will be an indirect inguinal hernia, and if it will be lateral to the below and lateral to the tubercle, it will be femoral hernia. Okay. So that was all about the anterior abdominal wall. Just a brief introduction of the posterior abdominal wall, because it is just a few slide, 1-2 slide. So posterior abdominal wall is formed in midline. So how it is formed? See, in the midline, there are the vertebra, 5 lumbar vertebra and their intervertebral disc, and then laterally 12th rib. See, this is the 12th rib, and then the upper part of bony pelvis. See, this is the bony pelvis. It is also included in the posterior abdominal wall, and then the few muscles. Now these 3 muscles are important: the psoas, quadratus lumborum, and iliacus. Okay, you can see here, this is the psoas muscle. It arises from these vertebrae and it goes down and attaches to the lesser trochanter of femur. And there, this is the quadratus lumborum. It arises from the iliac crest. It goes upward actually, and it goes to the 12th rib. Okay, see its insertion to the 12th rib. And then the iliacus, the name indicates it is in the iliac fossa. So it rises from iliac crest, and it also goes to the, with the psoas muscle, goes to the lesser trochanter. So these two are actually combined muscles, iliopsoas you can say, and they both have the same functions as well. Okay. So in posterior abdominal wall, or only these 3 muscles, I have told you just a brief introduction of origin, because psoas muscle arises from the vertebra. So 12 thoracic also included, and 5 lumbar, and inserted into the femur. Quadratus lumborum arises from iliac crest and inserted into the 12th rib. Okay, iliacus from the iliac fossa and lesser trochanter of femur. So both these psoas and quadratus lumborum supplied by the lumbar plexus, and iliacus is only supplied by the femoral nerve. Now, iliopsoas, basically they both have the same functions. Okay, because they are attaching to the femur. Okay, so they flex the thigh on trunk, both. Okay, and if you stable the thigh, then it flexes the trunk on thigh. Okay, the both the same functions, you can say, flex thigh on trunk, or they flex trunk on thigh. Like if you want to sit up from the lying position, then these 2 muscles, psoas and iliacus, they are used. The quadratus lumborum, you see it attached to the 12th rib, so it fixes the 12th rib. It's only related to the rib. 12th rib doing inspiration, the press 12th rib doing forced expiration, and laterally flex the vertebral column. Okay, so iliopsoas muscles, they are important as well. And these are the 2 ligaments which are formed by these psoas and iliacus, quadratus lumborum. Okay, so basically, psoas is enclosed in the fibrous sheath that is derived from lumbar fascia. The sheath is thickened above to form the medial arcuate ligament. See, this is the medial arcuate ligament. It is above the psoas fascia. Okay, so the lateral arcuate ligament is near surface of quadratus lumborum, is covered by fascia, which is thickened above to form the lateral arcuate ligament. So this is the lateral arcuate ligament above the quadratus lumborum. So you just have to remember that medial arcuate ligament is formed from the above the psoas muscle, lateral arcuate above the quadratus lumborum. Okay, you just have to remember the names of these. Okay. So that was the end of abdominal wall, anterior and posterior abdominal wall, inguinal canal, femoral triangle, everything related to the wall. Okay, so just the important points I've jotted down in this slide, the few basic points. The transpyloric plane, you remember it's the L1, bifurcation of aorta is at L4, dermatome of umbilicus. See, this is a dermatome, not the vertical level. It is T10. The deep membranous layer is called the Scarpa's fascia. Now, superficial inguinal ring is in the external oblique aponeurosis. Posterior layer of rectus sheath above arcuate line. See, like this they usually ask the questions. Okay, so above arcuate line, posterior layer will be formed from the transversalis and internal oblique muscle. Okay, so that was all about today's discussion. If you have any question related to this topic, you can ask. Any question up till now? Everything is cleared? Thank you. I have a few questions for you if you want to attempt these questions. You can unmute yourself, okay? If you cannot, you are not asking questions, then I should ask questions from you, okay? So there's the first question. Which structure enters inguinal canal and is identified easily at laparoscopy? So that's inguinal ligament, lacunar ligament, round or arcuate ligament. So
Round
who will
ligament.
go? Okay, that's great. So next is the which vessels can possibly be injured while inserting lateral ports in laparoscopy? That's the superior epigastric, inferior epigastric, superficial epigastric, or deep circumflex artery.
Inferior epigastric.
That's great. Okay, so which structure does not crosses the transpyloric plane? Not crosses, okay? So duodenojejunal flexure, pancreatic neck, tip of ninth costal cartilage, neck of gallbladder, hilum of kidney.
Neck
Now
of
you
gallbladder.
okay, you remember this because the fundus of gallbladder is actually
Ma'am, you
crosses it.
taught very well.
Thank you. You remember it. I am so happy. Okay, now what is the relationship between femoral nerve and femoral artery?
Nerve is lateral to artery.
That's great. So ये बस यही थे all questions. Okay, that's very nice of you. You performed very well. Okay, so anything else you want to ask about this? No. Okay, what you have to study in this anatomy module. This is only about actually the entire abdominal wall, anterior and posterior. Okay, so we're discussing the rest of anatomy. I have divided it into almost 6 lectures actually, because anatomy cannot be covered in one lecture. So I will be discussing everything into division wise. Okay, so this was all about, you just have to remember these few slides, and I don't think if you have these slides, you don't need to open up the books. Okay, so you just have to go through these slides and you just have to remember these points which I have told you in the video. Okay, so thank you very much. Or that's all. Let's end the meeting. Or anything you want to ask about anything, like in the booking process or any preparation? No? So ठीक है. ठीक. Okay, let's end the recording as well.